السلام علیکم ناظرین، میں ہوں الوینا اور آپ دیکھ رہے ہیں ہیلتھ ٹاک۔ ناظرین، انفرٹیلیٹی ایک ایسا مسئلہ ہے جو کہ کسی جینڈر سے ایسوسیٹڈ نہیں ہوتا، مرد یا عورت کا مسئلہ نہیں ہوتا، بلکہ یہ ایک ایسا مسئلہ ہے جو کہ کسی بھی جینڈر میں ہو سکتا ہے۔ ساتھ ہی ساتھ ایک جو بہت بڑا ایشو ہے وہ آج بھی پاکستانی سوسائٹی میں وہ یہ ہے کہ جب کوئی جوڑا بے اولاد ہوتا ہے تو انفرٹیلیٹی کے تانے صرف اور صرف عورت کو سننا پڑتے ہیں۔ تو یہ آج بھی ایک مت ہے کہ اگر کسی کا بچہ نہیں ہے تو وہ سارا کا سارا جو ایشو ہے وہ عورت میں ہے۔ سائنس نے اب یہ پروف کر دیا ہے کہ انفرٹیلیٹی کے ایشوز مرد اور عورتوں دونوں میں ہوتے ہیں۔ اب یہ ایک بہت بڑا مسئلہ نہیں، یہ کوئی خطرناک بیماری نہیں ہے، یہ ایک کنڈیشن ہے جس کنڈیشن کو آپ کیور کر سکتے ہیں میڈیکلی۔ بہت سارے پروسیجرز آ گئے ہیں، اب میڈیکل نے ایڈوانس اپنی سائنس کی وجہ سے، سائنس اور ٹیکنالوجی کی وجہ سے ڈفرینٹ پروسیجرز کو جو ہے عوام کے لیے بنایا ہے، اور ان پروسیجرز سے جو ہے لوگ مستعفی ہو سکتے ہیں اور لوگ ان پروسیجرز کے بعد صاحب اولاد ہو سکتے ہیں۔ آج ہم کانسیپٹ فرٹیلیٹی سینٹر اسی لیے آئے ہیں کہ ہم جانیں کہ آخر کیا وجوہات ہوتی ہیں انفرٹائل ہونے کی، اور انفرٹائل ہونے کی کنڈیشنز کو کیسے کیور کیا جا سکتا ہے، کیا ٹریٹمنٹس ہوتے ہیں اس کے، اور یہ پروسیجر کی کتنی لگ بھگ کتنی جو لاگت ہے کتنی لگتی ہے اس پر۔ یہ تمام تر سوالات اور جو بہت ساری متس آپ کے دماغوں میں یا ذہنوں میں موجود ہیں ان کو ہم جو ہے آج کلیئر کریں گے انشاءاللہ۔ جی ناظرین، اس وقت ہم موجود ہیں اندر کانسیپٹ فرٹیلیٹی سینٹر کے۔ کانسیپٹ فرٹیلیٹی سینٹر کی کراچی میں برانچ ہے، کراچی کے علاوہ جو ہے یہ ملتان، کوئٹہ، اسلام آباد میں بھی ان کی برانچز ہیں۔ بیسیکلی یہ جو سینٹر ہے فرٹیلیٹی سینٹر، یہ ایک آسٹریلین فرٹیلیٹی سینٹر ہے، وہ یہ پاکستان لے کر آئے ہیں، اور ڈیفینیٹلی آسٹریلین سٹینڈرڈز ہیں یہاں پر۔ اور جو لوگ جیسا کہ اپنے پروگرام کے انٹروڈکشن میں میں نے بتایا کہ انفرٹیلیٹی کا شکار ہیں، ان کو لگتا ہے کہ خدا نخواستہ بہت بڑی بیماری ہے، حالانکہ کوئی بڑی بیماری نہیں ہے، صرف اور صرف ایک کنڈیشن ہے جس کو آپ کیور کر سکتے ہیں۔ اور یہ تمام تر جو مسائل ہیں ان پر ہم آج بات کریں گے۔ ہمارے ساتھ ڈاکٹرز موجود ہیں پینل میں، میرے پاس نیشنل ڈاکٹرز بھی ہمارے ساتھ ہیں، ڈاکٹر ہیں، اور ساتھ ساتھ انٹرنیشنل ڈاکٹرز بھی موجود ہیں۔ میں ان کا تعارف کراتی چلوں تو میرے ساتھ موجود ہے ڈاکٹر جان کیون، اور ان کے ساتھ موجود ہیں ڈاکٹر گرام ٹامسن، اور ان کے ساتھ موجود ہیں ڈاکٹر سعدیہ احسن پال، اور ہمارے ساتھ لیز بھی موجود ہیں۔ لیز، ڈاکٹر گرام ٹامسن اور ڈاکٹر جان کیون آرٹلی، یہ تینوں ہمارے پاس پاکستان آئے ہیں پرتھ آسٹریلیا سے۔ تو آغاز کرتے ہیں ہم ڈاکٹر سعدیہ احسن سے، جانتے ہیں ان سے۔ السلام علیکم، آپ سب کو پروگرام میں فارملی ویلکم کرتی ہوں، اینڈ گریٹنگس فرام پاکستان، فرام مائی چینل اینڈ فرام می۔ ڈاکٹر سعدیہ، تھوڑا سا ہمیں بتائیں کہ یہ ورک شاپ جو بیسیکلی آرگنائز کی کانسیپٹ فرٹیلیٹی سینٹر پاکستان نے ان کولیبریشن ود دی آسٹریلین کانسیپٹ فرٹیلیٹی سینٹر، یہ بیسیکلی اس میں کیا سارے سیشنز ہو رہے ہیں؟
یہ بیسکلی انفرٹیلیٹی کے اوپر ہے، 2 دن کی کانفرنس ہے، 2 ہالز ہمارے چل رہے ہوں گے، اور انفرٹیلیٹی کے تقریباً میل اور فیمیل کے تقریباً سارے ایسپیکٹس ہم کور کر رہے ہیں۔ انٹرنیشنل ہمارے اسپیکرز آئے ہیں، ان کے علاوہ اور بھی ہیں، نیشنل اسپیکرز ہیں، ہمارے آئی وی ایف ایکسپرٹس جو پاکستان کے ہیں پورے پاکستان سے آ رہے ہیں۔ تو یہ اس طرح کی آپ سمجھیں کانسیپٹ کی پہلی انٹرنیشنل کانفرنس ہے جو اتنے بڑے اسکیل پہ ہم کروا رہے ہیں۔
تھوڑا سا فرٹیلیٹی کے کانسیپٹ کو ویورز کو سمجھا دیجئے کہ فرٹیلیٹی کا کیا کانسیپٹ ہے؟
دیکھیں، انفرٹیلیٹی کا کانسیپٹ یہ ہے کہ اگر کوئی شادی شدہ کپل کوشش کر رہا ہے پریگننسی کی، اور اس کو سال بھر کی کوشش کے باوجود پریگننسی نہیں ہو رہی ہے، تو اس کو ہم انفرٹیلیٹی کے اس میں لاتے ہیں، اور اس کی انویسٹیگیشن ہونی چاہیے۔ جب میں کہہ رہی ہوں سال بھر کی کوشش، تو اس میں یہ بھی ہے کہ دیکھیں اکثر کپلز شادی شدہ ہیں لیکن ہسبینڈ کہیں باہر ہیں، वाइफ इधर हैं तो वो काउंट नहीं करता ना, जब आप साथ नहीं रह रहे तो वो इनफर्टिलिटी में नहीं आता है। सिमिलरली अगर ख़ातून की अगर ख़ास तौर पे उम्र 35 साल से ज़्यादा है तो हम 1 साल भी नहीं इंतज़ार करते, फिर हम 6 महीने के अंदर
तो ये मिथ
करते
नहीं
हैं।
है, ये जेन्युइन बात है कि फर्टिलिटी जो है उसका उम्र के साथ ताल्लुक़ है?
बिल्कुल है, शौहर की उम्र भी काउंट करती है और वाइफ की भी।
तो मर्द की उम्र कितनी पर्टिकुलर कोई एज होती है?
देखिए एज एज सच नहीं होती, क्योंकि काफ़ी ज़्यादा उम्र में भी जाके मर्दों के बच्चे हो सकते हैं, लेकिन जैसे जैसे उम्र बढ़ रही होती है मर्दों की भी फर्टिलिटी कम हो रही होती है, ठीक है ना। तो
ये जो रेशो है या रेट है, ये औरतों में ज़्यादा मसला हो सकता है उम्र का, और मर्दों में उम्र के हवाले से
दोनों में
नहीं
होता है, दोनों में होता है, लेकिन औरतों का ज़्यादा इसलिए हम सीरियसली लेते हैं कि ऑन एवरेज पाकिस्तानी औरतें 45 टू 55 के दरमियान में मेनोपॉज हो जाता है, और मेनोपॉज इस वजह से होता है कि अंडे ख़त्म हो जाते हैं।
लेकिन इतना भी ये ज़्यादा रेशो हाई होता है 45 टू 50 में?
नहीं, ऐसा ही होता है पूरी दुनिया में, सारी औरतें एक ही जैसी होती हैं, थोड़ा थोड़ा रेस का डिफरेंस होता है। हमारे यहाँ इस उम्र में 50 साल एवरेज है, उस तक औरतों के बेसिकली मेनोपॉज इसलिए होता है कि एग्स ख़त्म हो जाते हैं। जब औरत के एग्स ही नहीं होंगे तो ज़ाहिर है प्रेगनेंसी कहाँ से होगी, तो इसलिए औरत की उम्र बहुत इम्पॉर्टेंट है। और इसीलिए हम कहते हैं, एक तो हमारे यहाँ लड़कियाँ देर से शादी भी कर रही हैं, प्रोफेशनल हो गई हैं, पढ़ रही हैं, जो कि बहुत अच्छी बात है, लेकिन हम यही कहते हैं कि एक दफ़ा शादी हो जाए और अगर आपकी उम्र 30 साल के करीब है या ज़्यादा है तो आपको फैमिली जल्दी कंप्लीट कर लेनी चाहिए, उसको डिले नहीं करना चाहिए।
अच्छा, तो इस वक्त जो अगर हम बात करें फर्टिलिटी के कॉन्सेप्ट को लेकर, तो शुरू में जब ये कई साल पहले जब ये कॉन्सेप्ट्स आए थे तो बहुत सारी मिथ्स थी उसमें। लोगों के हवाले से यहाँ पे ये भी कहा जाता था कि पता नहीं हलाल तरीका है या जायज़ तरीका है, नहीं है। क्या वो मिथ्स अभी भी फेस करनी पड़ती हैं आपको जब पेशेंट्स आते हैं आपके पास?
हाँ, करनी पड़ती हैं, इसलिए कि देखिए ये बेसिकली कोई भी इस तरह के जो टॉपिक्स हैं हमारे, ये एक तरह के टैबू सब्जेक्ट्स हैं, ज़्यादातर इन पे बात ही नहीं होती सोसाइटी में, ठीक है, घर पे भी, और बहुत ही मुश्किल से ही इस पे डिस्कशन होती है। हाँ, तो इसमें जायज़ ना जायज़ का कोई इशू है ही नहीं, क्योंकि पाकिस्तान में जब पहला टेस्ट ट्यूब बेबी हुआ था इंग्लैंड में, उसके 2-3 साल बाद ही फतवा आ गया था। अल अज़हर जो सबसे हाईएस्ट सीट ऑफ इस्लामिक लर्निंग है, वहाँ से आ गया था कि ये हलाल है, हो सकता है एज़ लॉन्ग एज़ शौहर का और बीवी का एग और स्पर्म इस्तेमाल हो।
तो क्या ये भी इस
तो
तरह कुछ इश्यूज सर्कुलेट हो रहे थे? अब वो उसमें कितनी सदाकत है कि गॉड नोज़ कि क्या इस तरह भी हुआ है कि जो पार्टनर्स हैं उनमें से जो आपका पार्टनर, जो आपका हस्बैंड है, उसकी जगह किसी और का जो
हमारे यहाँ हमारी नॉलेज में तो नहीं है कि पाकिस्तान में, बिकॉज पाकिस्तान में अलाउड ही नहीं है, दूसरे मुल्कों में है।
बट हाउ यू मेक श्योर कि ये जो है दोनों पार्टनर्स,
बिकॉज हमारे ही पेशेंट्स होते हैं ना, तो हमें पता होता है।
अच्छा,
तो ये इसका सवाल ही नहीं है, और पाकिस्तान में 1984 से ये अलाउड है।
अच्छा।
टेस्ट ट्यूब बेबी की ट्रीटमेंट, और इसमें कोई मज़हब की तरफ से कोई रुकावट नहीं है। और पहला बेबी भी हमारे यहाँ 19 इतना पहले हो चुका है पाकिस्तान में, और ये बहुत फ़ख्र की बात है कि हम बाकी मुस्लिम ममालिक की तरह हमने एक तरह से लीड ली है इसमें।
ठीक है। कॉन्सेप्ट फर्टिलिटी सेंटर के हवाले से
कॉन्सेप्ट फर्टिलिटी यहाँ नहीं था, कॉन्सेप्ट फर्टिलिटी ऑस्ट्रेलिया की ब्रांच यहाँ पर आई है, लेकिन ये कोई नया कॉन्सेप्ट नहीं है पाकिस्तान के लिए भी, पाकिस्तान में भी 1984 से हो रहा है।
ठीक है। थोड़ा सा बात जो है हम बाकी मेहमानों से भी करते हैं, फिर सादी आपकी तरफ आते हैं। डॉक्टर जॉन, हाउ डू यू से लाइक डू यू थिंक दैट कॉन्सेप्ट फर्टिलिटी सेंटर हैज़ द सेम स्टैंडर्ड्स व्हिच दे हैव इन पर्थ ऑस्ट्रेलिया, दे हैव द सेम स्टैंडर्ड्स इन पाकिस्तान एज वेल?
Yes, from my experience and speaking to the scientific team here, and also an independent scientist that's come across for the conference. There's it absolutely adheres to the same standards that we do. It's not surprising, perhaps. We were very helpful in setting up the clinic. Our scientific team came across and were helpful in that. And we're constantly in dialogue with each other and helping out if there are any issues. So, no, I'm very happy to say the standards are absolutely on a par with those that we have in our clinic in Perth.
Okay, so you completely have a faith that the standards are almost the same or actually the same?
I would say that, my experience, they're actually the same.
Okay, great. So obviously you're part of that conference. What things you think that you're going to deliver to other doctors here in Pakistan, or things which you're going to provide to Pakistani doctors here?
Well, I'm a plenary speaker, which means that I'm not necessarily presenting cutting-edge research. I'm a bit too old for that now. So I've been lucky enough, I've asked to do a brief talk on the history of IVF. I've been involved in IVF now for over 30 years, and I started my work in Cambridge, which is where Professor Robert Edwards did his original work. So I'm presenting it on the brief history of IVF, and then...
Would you like to give us a brief about what IVF is, what's that procedure, and what's all that?
Yeah, sure. I mean, IVF literally means in vitro fertilization, which means fertilization in glass. It's often, as you know, known as test tube baby treatment. It's been a while since we used test tubes. But basically, IVF involves removing eggs from the female partner and introducing them in the laboratory in a test tube, but now a dish, introducing them to the sperm from the male partner, keeping them in the right conditions, making sure that we pick out the best developing embryo. Fertilized egg then becomes an embryo, and then putting that embryo back into the woman's uterus in the hope of achieving a pregnancy. So that, in a nutshell, is what IVF involves.
So apart from IVF, which other procedure you think is really successful?
In terms of managing fertility in general, one of the most successful treatments we do is a lot simpler than IVF, and it's helping women who don't release eggs on a regular basis, who have irregular cycles. It's giving them medication to make them release eggs on a regular basis. And that is actually very, very successful indeed, and it's important to keep that in mind when one's assessing a couple, rather than necessarily racing towards IVF.
Okay, great. So now moving forward to Dr. Graham Thompson, we'll talk to him as well. What would you say about basic concept of infertility? What's that? I want to hear from you. Like, do you think that infertility is like women face it more, or it's like faced by both of the genders? It's not concerned with the gender.
It must be stated early that infertility is a couple's problem, not the problem of one partner or the problem of the other partner. One of the major aspects of development of fertility problems is delaying pregnancy. And that's down to the woman's age, unfortunately, but also male age is important as well. Patients, in our experience in Australia...
But I've seen men having a birth, like they can give birth in 70s as well, so that shows like male's fertility...
There is still a problem with the aging male, and that is that there's an association with what's now called autism spectrum disorder, so autism in the offspring. The other problem with male fertility later in life is producing a new male cohort, their sons, who will also face fertility problems.
Okay.
So it's multifactorial, yes.
Multifactorial, but still somehow I believe you guys don't want to say it, but you guys also feel that that infertility issue is still higher in women with regard to the age.
Yes, fecundity does that. Basically, a female's fertility goes along in a fairly straight line until 35 and then hits a parabola.
And there's another question which here in Pakistan people still believe, like there's some concerns like women who smoke a lot, or particularly a lifestyle, if she doesn't have a lifestyle, that's also going to affect her fertility. Is that right or just a myth?
It will affect the fertility, but it will also affect the pregnancy when they get pregnant.
Okay.
And so pregnancy outcome in people who have lifestyle problems, worse outcomes than if they don't have the lifestyle problems, like smoking and weight.
So it does affect, you say?
Yes.
Okay, it does affect. Okay, so it does affect. जिस तरह डॉक्टर थॉमसन भी कहते हैं कि वाकई लाइफस्टाइल का बहुत ज़्यादा फ़र्क पड़ता है और बहुत सारी चीज़ें हैं जो कि असर डालती हैं फर्टिलिटी के या इनफर्टिलिटी से कंसर्न होती हैं. गुफ्तगू का सिलसिला यहीं पे जारी रखेंगे लेकिन छोटा सा वक्फा लेना है. स्टे विद अस. वेलकम बैक आफ्टर ब्रेक. नाज़रीन, ब्रेक से कबल हम बात कर रहे थे कुछ इनफर्टिलिटी के मसाइल के हवाले से और गुफ्तगू में अब हम शामिल करते हैं अपने साथ लिज़ को भी. लिज़ थोड़ा हमें बताएंगी कि आखिर किस तरह सारा मैनेज होता है पर्थ ऑस्ट्रेलिया में कॉन्सेप्ट फर्टिलिटी सेंटर, और शायद उनसे कुछ हमें और अच्छी इंसाइट्स मिल सकें जो हम शेयर कर सकें अपने व्यूअर्स के साथ. सो लिज़, कमिंग टू यू, आई वुड लाइक टू नो फ्रॉम यू, लाइक व्हाट आर द स्टैंडर्ड्स ऑफ Concept Fertility Center. We're aware of the mission and vision of the organization, but how would you define the organization itself?
The organisation is very professional. We're there to achieve pregnancy outcomes for couples that come through the clinic, and it's a long journey for a lot of those women. We do offer counselling services as well to help them with their emotional support that they will need going through, and sometimes disappointment, unfortunately.
And what's the ratio of the disappointment?
We're looking at about 32% success rate.
Okay.
For Australia.
Okay, so coming back to Dr. John. John, there's a certain question which I always want to ask, but unfortunately I don't get a chance much to ask such questions regarding health, so today I have a good opportunity to ask from you. There's a lot of high ratio and high rate of miscarriages in Pakistan these days. I'm not sure whether it's across the globe, but particularly looking at Pakistan, I would say miscarriages are very common. Every other girl is facing miscarriage issue. The girl is perfect, healthy, very young, even she's in her 20s, but why miscarriage? She's not fat, she doesn't have any calories issue, she's not overweight, but why?
I think I'm not aware of any data that suggests that there's any particular population or area where the background rate of miscarriage is increasing. I think what is increasing is people's willingness to talk about it and be open about it, and I think that's all to the good because it helps to remove some of the stigma and the emotional trauma that's associated with miscarriage. I think it's important to bear in mind that as doctors we've always understood that miscarriage, early miscarriage, affects approximately 1 in 3 pregnancies. It's quite an alarmingly high rate. And one of the first things that we do with a lady who's having problems with miscarriage, maybe has had 1 or 2, is to actually just make that clear, remove some of the stigma and the trauma from them, because it's quite natural for people to feel that they've done something that may have caused this to happen. And unfortunately, the science says that when it does happen, in the majority of cases, the baby, sadly, was completely malformed, would have problems.
And Dr. John, why the miscarriage is frequent in first trimester? Why frequently?
Because that's the point at which the baby is laying down the bedrock, the foundations for future development. So the neurological system is forming. All of the systems in a baby are formed within the first 12 weeks of pregnancy. It's only after that, it's just a period of growth. So the
first trimester is actually very important.
Oh, vital, absolutely vital. It's the time at which the blueprint for the rest of the pregnancy is completely laid down. The size of the baby is probably predetermined. And as I said, all the vital organs, the vital structures are all formed by the end of the 12th week. So if anything goes wrong there, and I often make the analogy towards a computer program, if there's a glitch in the program, the whole thing crashes. And if there's a genetic problem with the baby, then unfortunately nature steps in and says, look, this isn't going to carry on, it can go no further. And therefore miscarriage, I'm sorry, is part of reproduction. It's a natural part of life. There are factors that can influence it. There are many, but probably not appropriate to go into at this point.
Dr. John, for instance, if we're talking about a girl who's still in her 20s and she has a good lifestyle, she has no medical issues again, but back-to-back having miscarriages, what's that again? Are some factors associated with that?
As I've already said, I mean, the fact that 1 in 3 pregnancies end in miscarriage in the first 12 weeks, possibly a little bit less in a younger person. You can relate it to age,
but that has activated in younger persons as well.
Yeah, but it's still 1 in 4. It's still 1 in 4. Now, the chance of somebody having 2 consecutive miscarriages is still only 1 in 16 if you do the maths. So 1 in 16 is actually quite high odds. I would back that in a race or a lottery. So it is quite common. As I said, there can be other factors. Certainly, smoking does impact on the risk of miscarriage. Whether or not people are in any way related, even relative, what might seem quite distant relations, can have an impact. But as I said, it's a common phenomenon. It's sad, but it's quite common.
Okay, so Dr. Graham, coming to you regarding the C-section or Cesarean operations. Here again in Pakistan, we're seeing very young ladies who are completely fit. They also face that C-section issue. Why not a proper natural birth? Why every other girl just a C-section option? Is it because of business? Doctors have made it a business because making money, or what?
There's more to it than that. And in fact, there will be a trend to perhaps have even more cesarean sections than there are now, because it's going to come down to the obstetrician to inform the patient that if they have a vaginal birth, a natural birth, they run the risk of pelvic floor dysfunction later and not being able to...
No, would you like to repeat it again? So you're saying like the impacts of C-section, the worst impacts, maybe you can say, are lesser than the natural birth?
No. There are 2 halves to this story, really. Cesarean section has got its own complications associated with it, and multiple cesarean sections have got more complications associated later.
Yeah.
I could enlarge on that, but I don't think it's necessary right now. But vaginal delivery is now being shown to have complications later.
Okay. So that's what people are unfamiliar with, that maybe, because
probably
people say the natural birth is the best option. C-section is like you have a whole cut off body, whole your life. And there are a lot of issues like there's a pain in your body, backache, severe backache. A lot of women get insomniac, they have depression. A lot of things are associated with C-section. They cannot do, they cannot train into gym properly, or maybe a lot of other things. Maybe some myths are also associated with that.
I think back pain and features like that are common to pregnancy, because pregnancy has hormones associated with it that soften up ligaments all over the body. Depression may be related to cesarean section for those patients who are hell-bent on having a vaginal delivery, but for some reason or other during the delivery, things fail and they have to have a cesarean section. So there's big depression or disappointment associated with that. And the same thing can be said about breastfeeding. Those patients that set themselves up that they must breastfeed, if they were unable to breastfeed because nature didn't deal them a good deal, then they get depressed as well.
Wow, that's a connection which God has created with the breastfeeding, so that releases mother from the stress.
Now there is an association, funnily enough, between cesarean section and the inability to breastfeed.
Yeah, that's another question.
And that's a question of timing. There's no easy way around that, in my opinion.
Okay, so again, I would persistently ask the same question, why? But still, doctors think that the ultimate solution for a girl, even in her 20s, is that C-section. I'll ask the same question, John, from you as well. What do you believe, or what's your verdict over that? But now, Thompson.
I don't believe that that's the ideal thing for a 20-year-old, no. I still believe that vaginal delivery is a good idea, despite what I said before. I don't believe, in Australia anyway...
But doctors here complain, they say like every girl has an issue, she cannot give a vaginal birth, and so that's why we're taking her to the C-section. But why? Why they're not giving the reasons?
I can't speak for Pakistan.
Okay.
But the concept, excuse the pun, the idea...
But how do you see in Australia, like what's the ratio over there of the natural birth versus the C-section?
I don't know the current figures, but I believe the last figures I saw was that it's supposed to be the norm for 25% cesarean section rate. But there are...
So 25% was the C-section?
Yeah.
Okay.
As opposed to 75% vaginal delivery.
Okay.
But there are places where your cesarean section rate is a lot higher than that. And it is true that in the private practice world, it's higher than in the public system.
Yeah, that's again. But there's again another thing. I'm particularly only talking about urban areas, not rural. In rural, we have more natural births. Yep. So again, it seems like maybe it's made commercial thing or what. It's a question mark in people's mind.
In Brazil, the cesarean section rate is very high, and that's because of maternal request.
Okay.
Because the female population there believe that if they have a vaginal delivery, their bodies will be destroyed forever. And there are cesarean section rates in Brazil that are approaching 99%.
But what do you believe? A body get more destroyed with which sort of birth?
Despite what I said before, I still believe that vaginal delivery is a good idea. If it works well and for the woman, it's an ideal situation. Pregnancy in itself will produce some pelvic floor dysfunction. Vaginal delivery will magnify that a bit. And I think I'm talking myself into a hole. But I still believe that vaginal delivery is a good idea. I do believe that somewhere around a 33% cesarean section rate is probably, or it should be, what we aim at.
Okay, Liz, so as you said that you guys deal with patient, you actually deals with them emotionally as well. So when patient comes to you, are they hopeless that they're infertile or they don't have kids? Do you guys console them, you guys consult them, and then you make them agree that this is the option, you'll have a baby? So what's that process and how do you do that?
Well, when we're talking to the patients, we recommend they see our counsellor because they've already been through some trauma or they might get some bad news in regards to their blood results, their sperm result, and they need ways to be able to deal with that. A lot of people tell their family and their friends, and so their family and their friends are asking them questions all the time about...
So this happens abroad as well?
Yes, absolutely, most definitely. So they constantly want to know the outcome, is it working, what's happening. As time goes on, people tend not to tell their family or friends because they need to be able to process some of that emotion themselves before somebody rings them up straight away and goes, oh, did it work for you? And they want to be able to just process it so they can get their own answer to know how to deal for it. If it works, then that's excitement. But if it doesn't work, then it can be very traumatic for them.
Okay, so most of the patients, they get, within the time passage, they get better when they come to
Oh yes,
fertility?
they do. Some of them need ongoing counselling because it's, you know, devastating that they haven't fallen pregnant again or they've done a frozen embryo transfer cycle. So that can also be devastating for them if it hasn't worked.
Okay.
They cry even when it has worked.
Oh.
So it's the same.
Dr. John, what sort of condition is azoospermia basically?
Well, azoospermia technically means that when the man produces a sample of semen for us to analyse, there are absolutely no sperm whatsoever in that sample.
So is azoospermia connected with the age?
The sperm count tends to decline with age, so it's not fair to say that men don't have fertility issues in older years. But it's not, azoospermia in itself generally isn't age-related. Most men who start off with a good sperm count in their teens and early adulthood, they don't tend to go to azoospermia as they get older. No, azoospermia tends to be caused by very unique set of circumstances. And essentially, it's either caused by a problem with the sperm being allowed to get out of the testis where they're made, or it's because they're simply not being made. So the factory's shut down, or the plumbing's wrong. And they may be born with defective plumbing. There may be part of the tube missing that allows the sperm to reach the outside world. Or they may have had an infection that's caused damage to the tube. And then the other big group are gentlemen where sperm aren't being made. Some of those are related to genetics. About 10% probably have a genetic fault that's caused it. But there's also another huge group where we don't really know why. We never get to the bottom of why they're not making sperm.
Okay, so are there certain reasons or like maybe particular reasons which causes azoospermia, or there are not particular reasons? I'll ask you this question. I would actually want the answer from you about this question, but I need to take a short break. We'll come back after a short break. Stay with us. Yes, Dr. John. So what are the conditions of azoospermia, like reasons basically?
Okay, so the reasons are that the man may have been born with part of the tube missing that allows the sperm to reach the outside world. He may have acquired a blockage through infection, or he may have been born with a genetic defect that means he doesn't make sperm. The genetic defect cannot be corrected. I'm afraid that's what you've inherited, and you can't overcome that. But we do have very successful means for overcoming problems where either bits of tubes are missing or blocked. There are techniques that can be used to recover sperm because the sperm are still being made. They just simply can't gain access to the outside world. Okay. There is also another small group, they do represent a small group, of men who've got hormonal problems that can be managed quite successfully. But they do only represent quite a small fraction of the gentlemen who present with azoospermia.
So is it curable?
Curable, cure in medical terms means you actually correct the underlying problem on a lifelong basis. We probably don't do that. We just get round the problem and we help them have a child. If we can do that. If we can find sperm and get sperm, then we help them have a child. But we don't usually go back and cure the problem in a strict medical sense.
Oh, okay. So it can be cured for a particular time. Means you can just have an outcome, you can have a baby with that, but you cannot correct it completely.
Correct.
But how that for a particular time when there are no sperms in?
Well, in the suitable candidates, and it probably represents about 40 to 50% of the men who initially present with azoospermia, we can recover sperm directly from the testis. But we can what we call aspirate sperm. It's quite a minor procedure, and in successful cases and in the right cases we can get sperm 90 to 95% of the time. And we can then store that sperm and use that as part of an IVF procedure with the gentleman's partner. So eggs have to be recovered because we only get quite small numbers of sperm, but we can quite successfully then inject a sperm into an egg, fertilise that egg, and overall those clients do very well indeed because it's a very discrete, absolute problem that you've managed to overcome by finding sperm and creating embryos. So the outcomes for those couples are amongst some of the best we ever achieve.
Okay, Dr. Graham, now there's a question which is slightly hilarious as well and confusing too. Earlier when these procedures came in Pakistan newly, so people had obviously one serious concern, which was whether it is haram or halal, whether like prescribed in our religion we can do that or it's not allowed in our religion. It was a sort of very difficult question for everyone. They thought that whether they should go for that procedure or not. And then coming on a lighter note, people also said that you don't have surety whether the sperms are of your partner or someone else. So was that some sort of thing which you had to face in Australia as well? Such questions?
No, not the way you had to in Pakistan. And I believe that that's still a problem in Pakistan. The donated sperm is...
But now there are a lot of patients going on, they're having treatments, they're having babies like that. But earlier it was sort of taboo, you can say.
Yes.
But the question still remains there, yes.
We in Australia didn't have that same problem because I think that in Pakistan it was based mostly on religion.
Yes.
And we don't have that problem.
But not connecting with the religion part. First question was connecting with the religion people had, whether this is correct or wrong. But the second part, which if I do not connect it with religion, the authenticity, I would say. Like, what's the authenticity that the sperm is correctly of your partner? And then again it goes indirectly or directly, you can say, with the religion as well. So this is haram, whether you have no authenticity, whether that's of your partner or somebody else.
I think what you're getting at is the way that we've evolved safe laboratory practice.
Safe laboratory practice, yes.
It's
like somebody else is not exchanging these sperms.
No, it's a case of having procedures in place, and we have them in Australia and they're replicated here, where it's very simple things like making sure that you don't have more than one sample of sperm actually on working with one sample more than one time. You also have things...
So authenticity was like a first and serious concern in Concept Fertility Centre.
It's always been a concern of laboratories, and the standards have only increased over time as we've become busier and more aware of the potential for harm that could be created. So there are now procedures in place, as I say, which, and it sounds simple, but it's actually it creates a real safety net. You make sure you only work with one sample at a time. There is what we call double checking, where two laboratory staff have to confirm against independent paperwork that this is the sample from that person. The same goes for embryos in the laboratory. You only work with one set of embryos at a time on a benchtop, and there's a constant audit and checking process going on. And we're also looking at introducing an independent electronic assessment, which I think if we do go down that route, we'll certainly be talking to Concept here about whether or not they want to follow on that one as well, where there's actually it's literally barcoding, tiny barcodes that go onto each and every dish, and you check those, and it's all computerized, and you've got a full audit trail of everything that happens.
Okay, but you got the question now. But still, again, there was a myth, you can say, that people said doctors trying to make their money. So in case if the infertility issue is 100%, they'll still say that you can be fertile and this is curable. So that's why they use other sperms and do that fraud. Did you face that such cases?
No, and I don't believe the premise is correct either. I think that I still hope to believe that the medical fraternity are treating that couple the only way that's possible for that couple. If there's azoospermia and there's no correctable cause, then donor sperm is the only option, or childlessness, or adoption. Now, in Australia, adoption is increasingly difficult. Very difficult, either onshore or offshore. Being childless for us in an infertility clinic is not an option. We try to make sure that everyone that we can will get pregnant and ultimately have a live birth.
Okay, great. So plus what would you tell to people who are facing this infertility issue? What would you tell them, like should they visit fertility centers, and what sort of patients should come indefinitely?
Traditionally, fertility has been defined as the lack of pregnancy over 12 months or 12 successful cycles. That has to be modified nowadays and taken the patient's age into account, And if a patient has not had a successful pregnancy and they're approaching a certain age where you know that the fertility is declining, then perhaps 12 cycles a year is not enough. It's too much time. So I would suggest if patients are concerned that they haven't achieved a pregnancy, and what will influence them is the fact that all their friends have achieved a pregnancy and they haven't. And so that will depend on their age group. And so I think that they should seek assistance. It doesn't mean going to somewhere like Concept straight away. They need to be channeled through their general practitioner, through their primary care physician first. And hopefully their primary care physician will see the problem, try to take care of as much of the problem that's within their sphere of expertise, and then transfer the patient to a centre of excellence if they can't achieve success for the couple.
Okay. Liz, you visited Concept Fertility Centre, Karachi branch, the branch which we are sitting right now here. So are you satisfied with the standards?
Oh, very much so. It's very similar to how we run at home, and everyone's care for the patients, and the standards are just as good as what we have at home. So there isn't any issues. I've been to the laboratory, I've been into the theatre, I've been with coordination, so I've been all over the unit. I've been here for a week now, so there's everything's running excellently. There's no problems at all.
Okay, great. Dr. John, anything you want to mention for people which are going through this infertility issue? You want to give them some message, or you want to explain something to them, any procedure or any advice?
I think what I usually like to say to my clients is that they are likely to face failure at some point. An initial cycle, even in excellent clinics like ours and like Concept Karachi, still more cycles fail than will work, at least at the first attempt. However, what's important to know is that there are a lot of studies, many studies, that show that if they keep trying, in most cases, pregnancy will, or stands a much better, will happen. And that an individual failure is not the end of the road, and that they shouldn't be despondent or destroyed because one attempt doesn't work. This is a long-term process, and they need to work with us, all of us in the fertility world, nurses, embryologists, clinicians. They need to work with us and understand that, and we can then help them.
Okay, and your message for people which are hopeless, almost hopeless?
It's never hopeless.
Never stay hopeless?
No, never say never.
Okay, great. Never say never. That's amazing. And the same question which I asked you, like what things you want here in this fertility center, like you believe in this fertility center they don't have it. They should also bring that stuff here, like any technology, anything.
The thing that is probably a stumbling block for Karachi is the cost of the treatment.
Again, that question stays. Like a lot of people believe that it's very expensive treatment.
And unfortunately, you don't have any government input into the costs. We are in a happy position in Australia that the government does have some input into the costs. And at Concept in Australia, we have fairly recently tried to reduce the cost to the patient. And that's part of the aims of Concept Australia. I don't know the easy answer for Karachi and for Lahore and Islamabad and the other concepts here.
Karachi is the city, by the way. People of Karachi face high inflation across Pakistan.
So I don't know. I don't think that there's the ability to influence the government to start pouring more money in it, because I don't think the government has that much money.
Okay.
Not an easy answer, I'm afraid.
Yeah, unfortunately, the previous corrupts have eaten up us much. They made their own properties and their own stuff, and they just
I'm not
kept
going to
us in
inflame the
debts.
situation by commenting on that.
Great. Okay, Liz, I just want to conclude it and would ask the same conclusion from John as well. Like, is that concern in Australia as well? In Pakistan, it's a high concern that it's a very expensive treatment. So in
It is
Australia
a
as
very
well?
expensive treatment. We have just offered something to help people make like a bulk billing thing, but we have government subsidy, which makes it easier. I think the reason why it's so expensive for here is that the drugs that we buy for private patients in Australia is very expensive. And if you can get your drug reps to cut those prices down, that's where a lot of your costs are. Whereas our patients in Australia can get it under script because they're allowed through the Artificial Reproductive Technology Act. As a patient here, you have to pay full price for that drug, and that is very expensive.
So Dr. John, apart from the government subsidy, do you have any charitable organizations also contributing for fraternity of fertility?
Not that I'm aware of. Obviously, a lot of our clients do have health fund insurance, which, if they've got the right level of insurance, will significantly contribute towards their costs. This is in Australia. But I'm not aware of any charitable groups that, certainly not in Australia, I don't know whether you have here, that will assist with that. I think it's possibly regarded as still being a little bit taboo for that kind of thing, a little bit of something that they wouldn't want to have themselves associated with. But I would agree, I think accessibility, to use a general term, is one of the key things from removing a lot of the stigma for couples, and the easier it is to access treatment, both financially and physically, then I think we've really arrived as far as the IVF world is concerned.
Okay, great. Thank you so much, Dr. John, Dr. Graham Thompson, and Liz. Thank you for participating in my program, and I hope a lot of misconceptions of the viewers must be cleared. बहुत सारी बातें जो concerns आपके होंगे infertility के हवाले से, उम्मीद है कि वो clear हुए होंगे. जिस तरह कुछ conditions होती हैं, ये एक myth है कि सिर्फ औरतों का मसला होता है, infertile होना या बच्चा ना होना सिर्फ औरत का मसला है. Infertility मर्द में भी हो सकती है और औरत में भी हो सकती है, लेकिन कुछ जो हमने आज के प्रोग्राम में जाना उसमें ये है कि औरत की उम्र वाकई थोड़ी इन्फ्लुएंस करती है, क्योंकि औरत को अपने वोम में बच्चा कैरी करना होता है, इसीलिए औरत की उम्र मैटर करती है, जबकि मर्द जो है उसकी फर्टिलिटी ज़रा उसकी ज़रा लंबी उम्र होती है, तब वो उसकी ज़रा कम होती है. लेकिन ये मसला दोनों में होता है. साथ ही साथ लाइफस्टाइल भी जो है बहुत ज़्यादा मैटर करता है. आपकी हेल्दी लाइफस्टाइल होता है तो फिर आपकी फर्टिलिटी के इश्यूज़ का मसला भी एड्रेस होता है. लेकिन ये कोई होपलेस होने वाली बात नहीं है. अगर आप ये फेस करें, आपका बच्चा नहीं है, तो आप कौन से फर्टिलिटी सेंटर आएँ या डिफरेंट फर्टिलिटी सेंटर्स में आएँ. यहाँ पर कराची में हाई स्टैंडर्ड्स के मौजूद हैं, पाकिस्तान में मज़ीद शहरों में भी मौजूद हैं. यहाँ पे आप अपना मसला जो है वो बयान कर सकते हैं और जो भी आपका मसला है वो उसको क्योर किया जा सकता है. तो ये कोई अनक्योरेबल और कोई ख़तरनाक बीमारी नहीं है, ये एक सर्टन कंडीशन है जो कि किसी भी इंसान के साथ हो सकती है. आज के लिए इतना ही. अल्लाह हाफ़िज़. गॉड ब्लेस यू ऑल.